This is the presentation for Chapter 36, Care of Patients with Pituitary, Thyroid, Parathyroid, and Adrenal Disorders. So there's a few disorders of the pituitary gland that we're going to discuss. We'll briefly discuss pituitary tumors, hypo and hyperfunction of the pituitary gland, diabetes insipidus, and syndrome of inappropriate antidiuretic hormone. Pituitary tumors are usually benign, which means not malignant or not cancerous in the majority of individuals. The cause of it is not known, but as we seen in the previous chapter, the pituitary gland controls a wide variety of things, such as the growth hormone, which stimulates growth, the thyroid stimulating hormone, which increases the secretion of the thyroid hormone, the luteinizing hormone, which controls ovulation for women, and testosterone production for men, among several other endocrine functions the pituitary gland is responsible for. So individuals can have a myriad of symptoms from a pituitary gland, depending on what things might be impacted. And so if it's depending on how large it is, it could be actually pressing against the optic nerve and causing some damage there, especially if it doesn't get relieved. So as I stated previously, these pituitary tumors can cause a myriad of symptoms. So depending on how much pressure it's putting on the brain, you might be experiencing headaches. Like I said, it could be putting pressure on the optic nerve, which could cause some visual disturbances, or even blindness can occur. The person might experience some personality changes. They might start to get weak or fatigued, depending on what's going on, and they might just have some abdominal pain that they have for years and not really have an official diagnosis of a pituitary tumor for many years. So a transsphenoidal hypophysectomy is the treatment of choice for pituitary tumors now. And so this treatment can actually cause acromegaly or gigantism, which we'll discuss here shortly, among some other diseases as well. It can produce some, cause some other diseases as well, because the pituitary gland produces so many different hormones. And so if you remove that pituitary gland, it can cause a lot of different issues. And so we'll discuss a few of them here shortly. The surgery can also serve as a palliative measure for individuals with metastatic breast cancer or pancreatic cancer, because as we stated, it produces the luteinizing hormone, which is responsible for ovulation in women and testosterone production in men. So by removing that pituitary gland, it helps to relieve and reduce hormonal secretions that and that can help with pain for those individuals. But back to these pituitary tumors, the hypophysectomy. So it's the removal of the pituitary gland, but it can occur subfrontally or transsphenoidally, which means They go through the inner aspect of the upper lip, through the sphenoid sinus, so up through, the nose area. Okay. After the surgery, we want to keep the patient on bed rest for a good 24 hours after the surgery, then encourage ambulation afterwards. You want to keep the head of the bed elevated because you want to avoid putting any tension or pressure on the suture line. You want to teach the patient not to sneeze or cough or blow his nose or bend over for several days to avoid disturbing the suture line. You want to give some mild analgesics as ordered for the pain. You want to probably anticipate the patient might develop diabetes insipidus, which we will discuss that here shortly as well, and what we'll need to do with that. Nasal packing. They'll have nasal packing for about 2 to 3 days after the surgery, and so and then they'll have a nasal drip pad under the nose as well. They should have some. You might see some minor bleeding or something on that pad, or some mucousy drainage. But if you see clear watery drainage on that pad, you want to report that immediately because that could potentially be cerebrospinal fluid, which would not be good. So you want to report that immediately. And then making sure you monitor the vital signs and the patient's neurologic status as well regularly. You want to teach the patient after this surgery, you want to teach the patient they're going to have to breathe through their mouth, because remember we said they're going to have the nasal packing and the nasal drip pad for about 2 to 3 days after surgery, so they're going to have to breathe through their mouth, and then also not to brush their teeth or cough or sneeze or blow their nose or bend forward, because you don't want to put any pressure on the suture line. And deep breathing, that's to prevent any respiratory issues or pulmonary problems after surgery. You don't want your patient to get pneumonia or anything like that. So as we stated before, the pituitary gland, one of the hormones it produces is the growth hormone. So growth hormone obviously means it stimulates growth in an individual. So if you have an excessive secretion of that growth hormone, you'll have what we call gigantism in children, or acromegaly in adults, if you have excessive secretion of that growth hormone. Stress, things like stress and pregnancy can cause an increase in that hormone to be released. So if you have an excess amount of the growth hormone being produced, obviously things are going to be enlarged or be overgrown. So your nose enlarges, your lips get thickened, your hands and your feet are going to be enlarged. You can get osteoporosis and joint pain as well. Amenorrhea in women. Amenorrhea means no menstruation. So their menstrual cycle will stop. Loss of facial hair and impotence in men. All these will be signs of excessive amounts of the growth hormone. So again, all these are the same nursing management, if we have to remove that pituitary gland, all those nursing management things that we discussed before, if we have to remove that the pituitary gland. So hypofunction of the pituitary gland is when you have a decrease in one or more of the hormones produced by the pituitary hormone. And so it could be caused by a few things. The most common thing would be a tumor, would be the most common thing. But your book on page 838, table 36.1, gives you some possible hormones that could be decreased and what you might see if those hormones are decreased. For example, if it's the growth hormone that's showing that's having a decrease with hypofunction of the pituitary gland, you will see a decreased muscle mass, the person might have reduced strength, or might have pathologic fractures. Also, it goes on to say, like, if it's the follicle stimulating hormone or the luteinizing hormone that are showing a decrease. Women, they might have irregularities in their menstrual cycle. They might have decreased libidos, decreased breast size. In men, if they had a decrease in one of those hormones, they might have testicular atrophy, which we already discussed. That atrophy meant muscle wasting. Decrease in the sperm, also a decrease in their libido. They might also be impotent, have decreased facial hair, decreased muscle mass as well. So it just kind of goes on there, and you can see, it shows you a decrease in the ACTH hormone, and then a decrease in the thyroid hormone. A decrease in the thyroid hormone is going to kind of be similar to the it'll look kind of similar to hypothyroidism. We'll discuss hypothyroidism here shortly. So for signs and symptoms, like we just discussed, it's going to depend on which hormone it is that's having the decrease in function as to what signs and symptoms you'll see. And like I said, that is on page 838, table 36.1, kind of describes some of the hormones and what you might see. Now, if this hormone or this hypofunction is due to a tumor, then all those signs and symptoms that we talked about with a tumor, that person might see, any of those signs and symptoms as well. So the headache, the visual changes. Now also anosmia. Anosmia is loss of smell, which of course we learned when we talked about the cranial nerves. And then they might have some seizures if it's due to a tumor as well. So it's all going to depend on, what the cause is and what hormone is affected as to the signs and symptoms you might see. So treatment and nursing management is, once again, it's just going to depend on what the hormone is, because they'll likely need lifetime hormone replacement for whichever hormone it is that's affected. And so then you're going to have to teach the patient about the hormone replacement, and that this is going to be, a lifelong thing that they're going to have to, do. And then also just monitoring for, any signs and symptoms of that hormone not being produced. Okay, diabetes insipidus. So we talked about this particular condition in the neural system. So it should be a little familiar to you, but it results from a deficiency in the circulating antidiuretic hormone. It's so the antidiuretic hormone, or ADH hormone, is synthesized or made in the hypothalamus, and then it's stored in the posterior pituitary gland. So the pituitary gland stores it and releases it when it's time. So when it is released into the general circulation, the ADH increases the water permeability of the distal and collecting tubules of the kidneys, which causes water reabsorption. If the ADH is not present or is absent, then the filtered water is excreted into the urine instead of being reabsorbed. And so as a result, you'll get large quantities of diluted urine occurring because that water is not being reabsorbed as it should be. It can be so diabetes insipidus can be caused by hypophysectomy. So if we remove the pituitary gland, we can develop diabetes insipidus, because of course we won't have that antidiuretic hormone being released, or some other type neurosurgery as well can cause it. It can be caused by a head trauma. That it can also be caused by infections, vascular lesions, or some type of autoimmune disorders as well. Here's a more extensive list of what things can cause diabetes insipidus. So things that are preventing that antidiuretic hormone from being released from the pituitary gland. So you have brain tumors, of course, as we already discussed, head injury, any type of neurosurgeries, and central nervous system infections can also cause diabetes insipidus. Nephrogenic. So nephrogenic means it can be caused by drug therapy, like lithium. You're taking lithium, or some type of kidney disease can cause it. And then also it can be caused by excessive water intake, which tends to occur more so in individuals with schizophrenia. So a cardinal sign of diabetes insipidus is going to be extreme polyuria. So polyuria means excessive amounts of urine, usually about 4 to 16 liters a day. And the urine is going to be very dilute. It's going to be pale, but it's going to be copious amounts of urine. I said 4 to 16, but it can get up to as much as 30 liters a day. So, and then there'll be a low specific gravity as well when we do the lab test. So they'll also have polydipsia. Polydipsia, which is excessive thirst, so particularly for cold drinks. Nocturia. Nocturia is urinating at night. Severe cases might have some fatigue and weakness as well. They're losing all that fluid, and so they could have some weakness. And if it's not treated, the person could go into shock. And so some signs and symptoms of shock might be cool, clammy skin. Skin might be pale, rapid pulse, rapid breathing, nausea, vomiting, enlarged pupils, or dizziness. So if the person is losing that much urine daily, they're gonna be at risk for dehydration. So then you would monitor for all these signs of dehydration, um, which of course you all know this. Poor skin turgor, dry mucous membranes, constipation, weight loss, muscle weakness, dizziness, tachycardia, hypotension. Hypotension. Always remember when when the blood volume decreases, your blood pressure decreases. So hypotension with dehydration. Okay, so these individuals are going to be losing large amounts of fluid, so we got to replace their fluid and electrolytes, obviously. We can give them oral fluids as well, but depending on the severity of it, that's probably not going to be enough, and they're going to need to have that supplemented with some IV fluids um, as well. And then hormone therapy, they're going to need to have that antidiuretic hormone replaced. So they're going to have a hormone therapy as well. So when we're talking about nursing management, we want to make sure we record the INOs carefully, maintain the patient's fluid intake to prevent severe dehydration. You want to watch for signs and symptoms of hypovolemic shock, like we discussed on the previous slide. So monitor their blood pressure, monitor their heart rate, monitor their respiratory rate, especially when they're having water deprivation tests. You want to do daily weight checks. And of course, when we have patients that we're doing daily weight checks, we want to make sure we weigh them the same time every day. So probably in the morning after they urinate, before they eat, wearing the same amount of clothes. Weigh them daily to see if they are losing weight. And INOs, obviously, because if they're losing all this fluid, we want to make sure we're monitoring that to make sure they're not putting out more than they're taking in. Remember to keep the bedside rails up and assist with walking. If the patient is dizzy or has muscle weakness, you want to monitor the urine specific gravity, because remember we said that can be decreased as well. And so watch for a decreased specific gravity, especially when they have increased urine output, which indicates an inability to concentrate the urine. And so we want to watch that as well. We had talked about constipation, so we want to add more bulk foods and fruit juices to the diet if constipation does develop. If necessary, depending on how bad, they might need a mild laxative or something. So you may need to get an order for that. You want to provide meticulous skin and mouth care. Apply a lubricant to any cracked or sore lips. If the dehydration is so bad that the skin is, dry. Make sure caloric intake is adequate and a meal plan is low in sodium, because the sodium, so make sure it's low in sodium. Watch for a decreased urine output and increased specific gravity between doses of medication. So you don't want to, you want to monitor that. Make sure things are improving. Monitor the patient's electrolyte levels and watch for hyponatremia. And evaluate the patient and teach them to maintain adequate fluid volume and electrolyte balance. And make sure they're resuming their normal elimination patterns. Okay, syndrome of inappropriate antidiuretic hormone, also called SIADH. So this is the opposite. This is the opposite of diabetes insipidus. So syndrome of inappropriate antidiuretic hormone occurs when the patient produces an excessive amount of the ADH hormone. So this leads to retention of fluid. So they're retaining fluid, and fluid is building up in the body, and they're going to have a loss of electrolytes, particularly sodium is going to be decreased because they're retaining so much fluid. Some of the most common causes of SIADH are central nervous system disorders such as head trauma, brain tumors, cerebrovascular accident, and Guillain-Barré syndrome. Another common cause could possibly be small cell cancer of the lungs. It can also be caused by pneumonia, tuberculosis. Some medications can cause it. Certain medications can cause it as well. So a patient with SIADH will have, so it's the opposite of diabetes insipidus, remember that. So this patient will have a decrease in the urine output, along with an increased concentration of urine. So their urine will be concentrated. The patient will also have signs and symptoms of low sodium levels. So all the signs and symptoms that you might have with low sodium. So fatigue, headache, decreased level of consciousness, nausea, vomiting, possibly seizures, even severe cases can be coma. When you have signs of low sodium, they generally become more pronounced when the sodium deficit is less than 120. So this person may also have some weight gain. They might have weight gain, increased blood pressure. So with this one, the fluid is increasing. So when the fluid volume increases, your blood pressure increases. Remember, we said when the fluid volume in the body decreases, the blood pressure decreases. So now this one is the opposite. With SIADH, the fluid in the body is increasing, so the blood pressure is going to increase. They may have some muscle weakness as well. I think I said weight gain. Weight gain is a possibility with these individuals. So the patient with SIADH requires a strict fluid restriction, typically about 500 to 1,000 mLs a day. This will allow the patient's blood volume to drop slightly, which will trigger the release of aldosterone. An increased amount of aldosterone will lead to sodium conservation. So you want to monitor the patient's sodium level daily until it begins to increase and get normal again. You want to make sure you explain to the patient why they're on a fluid restriction. Explain to the patient and the family about why they're on a fluid restriction, and have them participate in developing a schedule to distribute the fluid intake throughout the day. This will help them be more likely to adhere to the fluid restriction that's been put in place. You want to monitor the patient's level of consciousness. Is there any change in level of consciousness to ensure the fluid's not increasing in the brain or anywhere else for that matter. You might need diuretics to help get rid of some of that fluid buildup that the patient is having. You want to monitor their cardiovascular status, monitor their neurologic status as well. Make sure the fluid's not building up in the brain or around the heart or anything. Monitor the electrolytes, especially like I said, that sodium level. Make sure it's getting back to normal. Daily weights, again, you want to monitor daily weights to make sure they're not continuing to increase fluid intake. Hyponatremia can result in alteration in the patient's neurologic status. So hyponatremia, of course, we know is low sodium. And so our normal sodium level is 135 to 145. So we want to make sure we watch those levels on a regular basis. And just make sure the patient's adhering to that fluid restriction. So another endocrine problem is a goiter. So a goiter is simply, or not simply, but it's an enlarged thyroid. So a reason that you might have an enlarged thyroid, a couple reasons. You might have a deficiency of iodine in the diet, or you might have an increase in your thyroid stimulating hormone. Both of these could produce a goiter. And so now with the deficiency of the iodine in the diet, if you increase the iodine intake, it won't, your patients need to understand it's not going to cure the goiter, but it will stop it from growing any further. So the idea is to stop the growth, because as we'll discuss here, if it continues to grow, it's going to cause, other issues. But it's not going to cure it, but it will stop it from growing. In your book on page 842, you'll see a picture, figure 36.3, a picture of a goiter. And so basically you're going to see an enlarged front neck. You may have seen this before, but it's going to be an enlarged front neck. And so as I said before, we want to stop the growth of the goiter, because if it continues to grow, eventually it's going to start to possibly press on the esophagus, which is going to cause difficulty swallowing, or it's going to start pressing on the trachea, which will cause difficulty breathing. So either of these we don't want. So the idea is to stop it from growing. So like I said, this can be caused by a deficiency in iodine. So you can administer iodine preparations to help with this. But we can't, like I said, we can't cure it, but we can stop the growth of it. And sometimes, even the enlarged neck might go down a little bit. If you do give this iodine preparation, you want to make sure you dilute it and administer it through a straw, because it can stain the teeth, the iodine preparation. If it's caused by thyroid insufficiency, then they might give levothyroxine to help with that. So when you're given thyroid supplements, you want to make sure you're not over treating. So some signs and symptoms that it might be Overtreatment might be tachycardia, palpitations, nervousness, headaches, and fatigue. And then in some cases, dependent on if we're not able to stop the growth, we might need to surgically remove it. Some signs that the patient might not have an adequate amount of the therapy might be they might be having weight gain, dry skin, hair loss, impaired memory, or cold intolerance if they don't have enough of they're not getting enough of the thyroid hormone. Okay, hyperthyroidism. So this is a metabolic imbalance that results in an excessive amount of the thyroid hormone. The most common form of hyperthyroidism is Graves' disease, which increases T4 production and enlarges the thyroid gland, which is you'd have the goiter that we just discussed and cause a variety of different changes. Graves' disease is an autoimmune disease, and it's usually genetic in nature. Could be typically genetic in nature. Hyperthyroidism can also be caused by abnormalities in other glands other than the thyroid as well. It can be caused by abnormalities in the pituitary gland if it produces too much of the thyroid stimulating hormone. And smoking is actually also a risk factor for hyperthyroidism. So some classic signs and symptoms of Graves' disease would be enlarged thyroid. So like we said when we talked about the goiter, nervousness, extreme heat intolerance, weight loss. I mean, even though you have you're eating and have an increased appetite and keep eating, you still continue to have a weight loss. Sweating, diarrhea, tremors, palpitations, and then exophthalmos. Now that's if you look in your book on page 843, figure 36.4, you'll see a picture of a patient with this. It's the enlarged eyes. You can see how the eyes are kind of just bulging out of the head with Graves' disease. That's a key indicator of Graves' disease as well. These people might have insomnia, so having difficulty sleeping at night. Agitation might be something with them, and exertional dyspnea. So they get dyspneic when they exert themselves. So these are some other signs and symptoms you might see with your patient with hyperthyroidism. They might have ankle edema, difficulty concentrating, or diarrhea, excessive thirst and urination. Remember we said excessive thirst was polydipsia, excessive urination was polyuria. Decreased libido, scanty menstruation, that just means decrease, and possibly infertility might be a symptom with hyperthyroidism. So with treatment, most patients can lead normal lives. However, a thyroid storm can occur which is an acute exacerbation of hyperthyroidism. Um, this is a medical emergency that can lead to heart failure, and with the thyroid storm, they can have irritability, hypertension, tachycardia, vomiting, temperature of 106 degrees, delirium, and they can even have go into a coma as well. So, we don't want these individuals to go into this thyroid storm, which is the exacerbation of the hyperthyroidism. And so we had talked about them having the goiter, because that would be a result of the Graves' disease and the exophthalmos as well. Emotional upheaval, just uncontrollable crying and depression, a lot, as well as something other things that can occur with just hyperthyroidism. Okay, so you want to make sure you take care to prevent acute exacerbations and complications from occurring. So you want to make sure you record their vital signs, record their weight, monitor their electrolytes, monitor their cardiac function, because remember we said if they go into that thyroid storm, it can cause cardiac problems. Check their level of consciousness and their urine output regularly. So these people could have ablation, which is a radioactive iodine to treat the hyperthyroidism. So you have to be careful with this radioactive iodine, because if they have too much of it, it can cause the opposite effect and cause hypothyroidism. With the radioactive iodine, they can have the opposite effect and cause hypothyroidism. Or you want to make sure they're getting enough treatment so that they're not going into a thyroid crisis. If they're not getting enough treatment, they can go into the thyroid crisis. With the radioactive iodine, though, you got to take care and be careful, because all the patient's body fluids will be radioactive for a little while after they receive this radioactive iodine. So all their blood, body fluids will be radioactive. The blood, anything excreted from the kidneys. So when you're handling anything with blood and body fluids, you want to take precautions. So when you're handling their needles, when you're handling their syringes, when you're handling their bedpans or their urinals or any specimen containers or anything, you want to take precautions, because you don't want to you don't want this touching your skin. So hypothyroidism is a state of low serum thyroid hormone levels, or resistance to the thyroid hormone. So it can be caused by iodine deficiency. It can be caused by some type of inflammation of the thyroid gland. It can be caused by a decrease in the thyroid stimulating hormone secretion, hypothalamus. So if you have some type of dysfunction in the hypothalamus, that can cause it. Atrophy of the thyroid gland, so muscle wasting. If the thyroid gland is wasting away, treatment of hyperthyroidism. So remember we said that radioactive iodine, if you give too much of that radioactive iodine when you're treating hyperthyroidism, it can cause hypothyroidism. So just remember that pituitary dysfunctions can also um, cause this. Thyroidectomy, so removing the thyroid, um, can cause hypothyroidism as well. So when we're talking about signs and symptoms, things are slowing down with hypothyroidism. Things are slowing down. So in children, they might be sluggish a few weeks after being born. They might have a delayed physical and mental growth um, in children. And then when we're talking about adults, they might be sluggish in their mental and physical activities. Things are slowed down. Speech is slurred. They're lethargic. Um, Abnormal sleep patterns, not sleeping well. Decrease in appetite. They have a decrease in their appetite, and they're gaining weight, even though they're not eating much. They're gaining weight because their metabolism has slowed down. So since their metabolism slowed down, they're not burning those calories. So the weight gain is increasing. Bagginess under their eyes and swelling in their face. Some other signs and symptoms, cold intolerance. So constipation, because like I said, everything is slowing down, including the digestive tract. Things are slowing down. It's not moving through like it should be. So constipation, they might have some impaired memory, depression, husky voice, thinning eyebrows, hair loss. They might bruise easily, be fatigued, have dry skin, non-pitting edema as well. And so non-pitting versus pitting edema. Pitting edema, when you put your finger into the skin and it has that indent left there, that would be pitting. If there's not an indent, but there's some edema there, then it would be non-pitting. Okay, so you want to provide a high bulk, low calorie diet and encourage the patient's activity because we said constipation. So remember, high bulk, fiber, those things can increase in their activity to help, with that constipation. They might need some stool softeners or something as well, depending on the degree of the constipation. Um, so when you have thyroid replacement therapy, you also want to make sure they're not getting too much. So you're going to have to monitor for some signs of all those signs of hyperthyroidism. So when we talked about hyperthyroidism, the restlessness, the sweating, the excessive weight loss, things like that. So monitor for that once you start the hormone therapy. Make sure they're not getting too much of that. You want to evaluate the patient, make sure their bowel elimination is back to a normal pattern. Their cardiac function, you want to monitor their cardiac function is at a normal, like it should be. We had talked about dry skin. So when they have dry skin, you want to make sure you keep their skin, lotion with cream so it's not getting dry and cracked or things like that. Because they will have that cold intolerance. Make sure you're providing warmth. So, do they need a blanket? Does the temperature, check the room and the temperature in the room for them. And that their daily thyroid medication. This is going to be something, lifelong, that they will have to take this thyroid medication. And don't rush the patient. Remember, we said everything's slowing down, so they're moving a lot slower. So we're not going to rush our patient. Um, Allow them, time to do the things that they need. Okay, so your patient is likely going to be on levothyroxine, which is your thyroid replacement um, hormone. So levothyroxine should be taken on an empty stomach about in the morning, likely in the morning, usually about 45 minutes or so before you take any other medications or before you eat. It needs to be on an empty stomach to ensure that it is properly absorbed. So, like I said, about 45 minutes before any other medications, it should be taken by itself and on an empty stomach without food. Your patients need to understand that this is going to be a lifelong therapy, and they cannot just stop this treatment at any time they, feel like they're feeling better or whatnot. Like, speaking of feeling better, make sure your patients understand that it could take up to 6 to 8 weeks for them to actually feel the benefits of the levothyroxine, so that they're not expecting after a couple of doses they should be feeling better. And if they don't, they think it's not working. Let them know it could take up to 6 to 8 weeks before they feel significant benefits. Instruct them that they should let the physician know if there's any unusual bleeding or bruising or chest pain or palpitations or anything like that. Also, teach them about signs and symptoms of mixed edema. Mixed edema is severe hypothyroidism. So that's a severe form of hypothyroidism, and that means that the something's not right. The medication would need to be adjusted. So signs and symptoms of that might be dizziness, respiratory distress, low blood sugar, or hypothermia. Hypoparathyroidism stems from a deficiency in the parathyroid hormone. Because the parathyroid hormone primarily regulates calcium balance, hypoparathyroidism leads to hypocalcemia and produces neuromuscular signs and symptoms that range anywhere from paresthesia to tetany. The clinical signs are usually can usually be corrected with replacement therapy, but there are some complications that can occur with the disorder if it's not corrected, such as cataracts, and that can be irreversible. So when we're talking about hypoparathyroidism, we definitely know that this comes with hypocalcemia. So we would need to know signs and symptoms of hypocalcemia. So hypocalcemia produces muscle tingling, numbness, muscle cramps, and some mental changes as well. But two key indicators for hypocalcemia are Chevestek sign and Trousseau sign. Now, with Chevestek sign, you would tap along the patient's face, and you would notice some muscle twitching in the face. So you tap down the patient's side of the patient's face, and then they'd have some muscle twitching, which would be Chevestek sign. Trousseau sign is when you put a blood pressure cup on the patient, just the way you normally would, and you inflate that blood pressure cup 20 millimeters of mercury above the systolic blood pressure for about 3 minutes. And then you're going to notice the flexion in the wrist and the metacarpal joints. So you'll notice that the wrist will flex and the metacarpal joints will flex as well. That's Trousseau sign. So those are two really key indicators, Chebystek sign and Trousseau sign of hypocalcemia. Also with hypocalcemia, we're going to notice some tetany, which is twitching, and spasms. Now, if it continues to be a problem and you don't get this calcium level corrected, then the patient could start to have convulsions or cardiac dysrhythmias, or spasms in the larynx. So the goal of treatment with hypoparathyroidism is obviously getting the calcium levels back to normal. It's an obvious key treatment. But other things we want to make sure, probably institute seizure precautions, because like I said, in severe cases it could lead to seizures. They might even have a trach kit at the bedside, because like I said, severe cases again, you can have spasms of the larynx. So having that trach kit at the bedside could be beneficial. You want to monitor the patient for the Chebystek sign and the Trousseau sign, as I indicated. You want to, they'll probably have some electrolyte replacements as well. Patient needs to know this also is a lifelong therapy that they'll be having, and so they'll probably want to wear a medical alert bracelet as well. Okay, hyperparathyroidism is the result of excessive activity of one or more of the 4 parathyroid glands, which results in excessive secretion of the parathyroid hormone. The parathyroid hormone. So this increase in the parathyroid hormone promotes bone reabsorption, and which will lead to hypercalcemia and hypophosphatemia. So when we're talking about high calcium levels, which is hypercalcemia, we need to know what are signs and symptoms of hypercalcemia. So that would be dehydration, confusion, lethargy, arrhythmias, anorexia, nausea, vomiting, weight loss, constipation, thirst, frequent urination, and hypertension as well. And if we don't get this under control, get the hypercalcemia under control, it can cause a thinning of the bones, and then cause bone cysts can start to occur, which of course, thinning of the bones and this whatnot, patients could have fractures easily. Okay, so they'll probably be forcing fluids to help decrease the calcium levels. So we want to make sure we monitor our INOs every 2 to 4 hours, and get daily weights on this patient to ensure they're not, getting too much fluid. You're going to strain their urine and to check for any calculi or whatever. You're going to monitor their electrolytes, probably sodium, potassium, magnesium levels. You want to monitor those regularly, and they're probably going to limit their calcium intake as well. They may be using normal saline also. Okay, so the next two conditions we'll talk about are Addison's disease and Cushing's syndrome. And both of these conditions are the result of an imbalance of the corticosteroid hormones. Okay, so the two corticosteroids that are particularly of concern are the cortisol and aldosterone. When you talk about cortisol, cortisol helps to exert what's called permissive action, meaning the cortisol is an essential ingredient for many bodily functions, such as it helps with the maintenance of normal electrical excitation for the heart and the brain. It helps to maintain normal blood glucose levels. It helps with metabolism of proteins, fats, carbohydrates, and it also helps maintain normal vascular volume as well. The aldosterone is the key action to help with kidneys, help the kidneys to regulate water balance. And so it does that by encouraging the kidneys to save sodium and excrete potassium. So when these levels are off, you're going to see some of the signs and symptoms that we will talk about here with these two particular diseases. All right, so let's start with Addison's disease. Addison's disease, which is also called chronic adrenal cortical insufficiency, it's a rare disorder, but it results from chronic destruction of the adrenal glands. The adrenal glands are located just above the kidneys. And so, if we have destruction of those glands, then it's not secreting the hormones that we need. And so, this in turn leads to insufficiency of the adrenal steroid hormone production. Okay. Um, these patients might complain of a variety of things, such as weakness, fatigue, weight loss, activity, and stress intolerance. So the cortisol helps the body to respond to stress. And so if you have a decreased production in the cortisol, you'll have an intolerance to stress. So that's why you might see that in these patients. You might also see dizziness. The patient might report a craving for salt. And so remember, we said that the kidneys aren't able to save the sodium. So they're going to be losing excessive amounts of sodium. So they might be craving salt. They might have anorexia. Don't get that confused with anorexia nervosa, which is a mental disorder. Anorexia, anyone can have, from sickness or illness. It's just the lack of desire to want to eat. So anorexia, nausea, vomiting, diarrhea, right? All those things further, lead into the weight loss. When you inspect these individuals, the most dramatic finding for patients with Addison's disease might be increased pigmentation of the skin. And so it kind of resembles like a deep suntan or something like that, particularly in the creases of the hands or even over the joints or whatever. And so this occurs because of elevated levels of the pigment producing cells. Okay. When you examine these or complete a physical examination on these individuals, you might find signs and symptoms of dehydration. So you know those signs and symptoms of dehydration, things like poor skin turgor, dry skin, dry mucous membranes, things like that, all those signs and symptoms of dehydration. So don't forget about, what those might look like, because you could see that in these particular patients. Um, Decrease axillary or pubic hair might be something you see in these individuals. These patients might have a weak or irregular peripheral pulses. Low blood pressure could be an issue as well because of the fluid volume deficit. So remember, the blood pressure is going to follow the fluid volume in the body. So if we have fluid volume deficit, our blood pressure is going to decrease. Remember, you could have these cardiac issues. The kidneys might not be able to excrete the potassium, so therefore got cardiac issues. These patients might suffer from postural hypotension, tachycardia, confusion. All these things might be a result of what you might see in your patients with Addison's disease. And so, if the situation is not under control, then the symptoms can become exaggerated and cause what's called an Addisonian crisis. An Addisonian crisis, the person's blood pressure is going to be very low. Their blood sugar is going to be very low. Their potassium is going to be very low. And so, as a result, um, if the person goes into Addisonian crisis, this is a life-threatening situation or a life-threatening condition that needs to be addressed immediately. And so nursing, for a person that is in Addisonian crisis, nursing interventions are going to focus on immediately correcting the fluid volume deficit. And so the nurse will need to administer fluids rapidly through a large bore peripheral IV. And so because it's going to be going so fast, during fluid infusion, you want to make sure you monitor the patient's intake and output, and evaluate, for signs of fluid overload. Signs of fluid overload could be pulmonary congestion, dyspnea, distended neck veins, and tachycardia, are all signs and symptoms you want to make sure you monitor for in these patients. The person might also need a Foley catheter to help, with if you're measuring uh, intake and output, to help make sure you're monitoring strict INOs appropriately. Okay, so your person with Addison's disease, um, you're going to have to do corticosteroid replacements. So we want to prevent them from going into this crisis. So we're going to have to do corticosteroid replacements for these individuals. Usually with cortisone or hydrocortisone or something like that would be the primary lifelong treatment for these patients with some type of primary or secondary adrenal hypofunction. So like I said, we want to, prevent them from going into any type crisis. So they would need, since they are having decreased corticosteroids, we need to replace that. Okay, so Cushing's syndrome, that's when you have too much of the corticosteroids. So it's going to be opposite of Addison's. You have, with Cushing's disease, you have too much of the corticosteroid. And so it can be caused by a few different things. The primary cause could be a pituitary gland adenoma. So, an adenoma of the pituitary gland, and it's causing corticotropin secreting cells. So, it's secreting excessive amount of the steroid. Other causes you might have a cortisol secreting tumor in the adrenal cortex, or tumors in the lungs or the thymus gland, all those that are secreting excessive amounts of that hormone, causing you to have excessive corticosteroid in the body. Also, if you're having using long-term corticosteroid therapy, um, can cause you to develop Cushing's disease, right? So anything that's going to cause hypersecretion of the corticotropin hormone, okay, can cause this Cushing syndrome. And so with Cushing syndrome, you're going to have lots of different signs and symptoms. So that could be adiposity of the face, the neck, the trunk. When you look at the face, when they say adiposity of the face, that's what they call that moon face. So that moon face, rounded looking face. Purple striae, which are stretch marks on the skin, especially on the abdomen, you might see this. This Cushing syndrome is actually more common in females than males. Not saying males can't get it, but it's just more common in females. You also might see weight gain with these individuals. muscle weakness, fatigue. That they have what's called the buffalo hump. You may be familiar with seeing the buffalo hump. Um, Thinning extremities with the muscle wasting. Um, Thin, fragile skin. Like I said, the moon phase. Um, Hirsutism, which is excessive growth of hair. So excessive growth of hair. Um, Also, if they have any wounds, it may be difficult for these wounds to heal as well. Maybe they have bruising easily, can also be an issue with these individuals. So, for patients with Cushing's syndrome, the goal of therapy is to restore hormonal balance and reverse the physiologic changes that occur with the syndrome. Some patients may need some type of surgery, to remove um, the tumor or, remove it. Or radiation might be, an option for some individuals. If the adrenal gland is entirely removed, if they have to remove the adrenal gland entirely, um, or if it's destroyed completely, then that person obviously will require lifelong corticosteroid therapy because they won't have that gland there anymore. Okay, and so like I said, we want to try to restore balance, so remove the tumor or whatever is going on. Okay. Okay, so for our nursing interventions or nursing management, we're going to frequently monitor our patients' vital signs, especially their blood pressure. And so you want to observe the hypertensive patient um, who has, especially if they have cardiac disease or something like that. Monitor for hypernatremia, hypokalemia, hyperglycemia, and glycosuria, which is obviously glucose in the urine. Okay, so this patient with Cushing's syndrome is likely to retain sodium and water. So as a result, you want to make sure you check for edema and carefully monitor daily weights. So remember, when we're monitoring daily weights, we want to do it in the morning, after they urinate, before they eat. Same amount of clothes, same scale if possible. We're going to monitor intake and output. Okay, and so to minimize weight gain, edema, and possibly hypertension, you're going to talk to or consult with the dietitian to ensure they have a diet that's high in protein and potassium, but low in calories, low in carbohydrates, low in sodium. Okay, you want to watch for infection because these individuals are at risk for developing infections. Okay, you want to, if the person is bedridden or has osteoporosis, you want to, carefully do your passive range of motion exercises for this patient. The person with Cushing's syndrome can be emotional. Remember, we said that cortisol helps the body when it comes to stress. So if there's an overproduction of that, there could be some emotional, excessive emotional issues going on there. So you want to monitor for that. Offer any emotional support, throughout this period. Um, it could even get to the point where that sedation may be necessary, but we're going to monitor our patient carefully before we get to that point. Make sure you're helping the patient get the physical and mental rest that they need as well. And make sure you're evaluating the patient. So after you've completed the therapy or whatever it is their treatment that they're receiving, make sure you recognize any signs and symptoms for steroid underdose or overdose that they may be receiving. And the person will probably need to carry medical ID. Okay. So just making sure, we're monitoring fluid and electrolytes and cortisol levels as well, with this patient. Okay.